Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. I welcome one and all for this class today. And this is a class on the DNB October paper number 1 discussion. Okay, so let's start with the first question. It was asked that describe the changes in the vascular architecture of the uterus and the endometrium in pregnancy. See, this is a the basic sciences paper. So they'll ask you very basic things. Okay, so you have an example. Describe the changes in the vascular architecture of uterus and endometrium in pregnancy. So how the vascular thing changes and how the uterine lining and uterus and everything it changes in pregnancy. This is what we have to talk about. So let's begin with uterine vasculature first. So there is a lot of hypertrophy and blood flow during the pregnancy. So what happens is that because of uterine hypertrophy and the size increases, you have a lot of blood flow to the uterus increases. So 50 ml per minute pre-pregnancy is the blood flow. It changes to almost 1 liter per minute at term. That's the level. Okay, because now it's supplying the pregnant uterus. So it's the baby is developing there and the size has been increased, the placenta, the amniotic, everything is there. So therefore, the amount of blood reaching also increases. Okay, and then you have the uterine arteries, they undergo remodeling. And I'll talk about that more in the next section. The idea is to reduce the vascular resistance. So how do they do that? They become low resistance, high capacitance blood vessels. So I'll tell you what exactly happens. Then you have the VEGF and the placental growth factors. They increase because they are the ones which are responsible for angiogenesis and the vasodilatation. So VEGF and placental growth factor, they increase. Remember, they should increase, which is also the basis of the test called placental growth factor test for predicting the development of adverse outcomes or development of adverse outcomes in preeclampsia. So if the placental growth factor is reducing or it's stagnant or less than normal, that means you are having serious problems in this pregnancy of yours, and you can go in for severe adverse outcomes. Correct? Now, spiral artery remodeling is one of the features. Okay, this is the vascular architecture going on. So what happens in the spiral arteries is, that there is an invasion of trophoblasts. This is very important. What do they do? They invade into the spiral arteries, and in the first trimester and the second trimester. So what they do is basically there is a loss of smooth muscles and elastic lamina. So they become high capacitance and low resistance. Correct? This is the idea. So there is a loss of smooth muscle and there is a loss of elastic lamina. So conversion of these arteries into low resistance and high capacitance, right? So this trophoblastic invasion wave we talk about is absent in patients who are destined, programmed to develop preeclampsia. Correct? Otherwise it happens. Now what happens to the endometrial vasculature? So again, they have the same angiogenesis is there. Then you have more circulation, rapid circulation, more, these vessels, they develop less resistance, high capacitance network. And of course, they are highly branched capillary systems, and because of which you get more and more blood supply. Right? Now, even the one more thing was there. Yes. So what happens to the endometrial blood vessels? This is what happens. Again, endometrial vasculature, this is what happens. The basal layer, this is what I wanted to specify to you, stress upon this. The basal layer of the endometrium, again, there is more, because they are the ones which are contributing to the uteroplacental circulation, that there is more of angiogenesis in the desva basalis, and there is more of remodeling in that vasculature to improve the maternal and fetal circulation. This is what I wanted to specify. Plus, of course, the placental vascular network is highly branched and highly vascularized. Okay. Now, see, these are all 2-mark questions. Okay, guys. So you need to just write down few points and maybe one sentences each. Okay. I've still managed more because my students are never satisfied with less. So I give them more, but that does not mean that you have to fill pages. Otherwise, you'll not be able to do justice with the 6-mark questions or 8-mark questions. And you see, even in these questions, the 6-mark question is also so small. I'll tell you, because what it was is very, very basic. The definition of two things is 2 points each. So 3 marks, 3 marks. One for the definition and 2 marks each for the 2 examples. The moment I understood it, I made it very crisp. Because that's the way of writing exams as well. Discuss the abnormal vascular changes seen in pregnancy with preeclampsia. Now I want you to tell me, I told you the basic. Now you tell me what happens in preeclampsia. And this is a 2-mark question. So I need only the points. If you give me 2 points and those 2 points are justified, there's no need for you to write down anymore. So I want my students now to tell me, what do you think happens with preeclampsia? Come on, guys. Let me know. One answer is right in front of you. And if you start writing like this, you will get the points in the exam like this, okay, in a blink of an eye. And then you won't have to stress any further. See, a lot of time is wasted in recollecting things in the exam, isn't it? So if you are in a habit of writing down, penning down, things become very smooth in the exam. All right. So yeah, please tell me. Okay. Yes. So there is defective. So first of all, I think you can say that there is defective trophoblastic invasion in the first and second trimester. So the trophoblasts, they do not replace the muscular wall of the arteries, the uterine arteries, and there is no invasion of the elastic lamina. So they continue to become high resistant vessels, because of which the vascular, the blood supply is diminished. Does not happen exactly. So, anything else that you want to share? Yes, guys? Anything else that you want to tell me? You want to add? Yes, very good, very good, very good. So these 2 things, if you say, that there is defective trophoblastic invasion and endothelial injury, they are 2 very important aspects of what happens in preeclampsia. Endothelial injury is going to tell you the reasons why you are having cerebral edema, pedal edema, and acute kidney injury, and of course all the LFT KFTs that go deranged. And your defective trophoblastic invasion will tell you why you have placental dysfunction, why you have FGR, why do you have oligohydramnios because of preeclampsia. So there are 2 very, very important entities. Both are related to vasculature. And now I'll tell you. See, this is what I've written down over here. The most important is defective spiral artery remodeling and endothelial dysfunction. Because of these 2, there is all the changes that happen in preeclampsia. Okay, so there are narrower high resistance vessels which restrict the blood flow to the placenta, as a result of which you have all these problems. What? You have FGR, you have oligohydramnios, you have placental dysfunction, correct? And because of this endothelial dysfunction, you have vasoconstriction, hypertension, and most important is the multi-organ dysfunction, I would say. If there's anything which this endothelial dysfunction does, it is the multi-organ dysfunction. Now enumerate 4 important risk factors for the development of preeclampsia. Now according to you, what do you think? Just enumerate 4. Tuck, 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 tuck. Give me 4 of these. The risk factors for development of preeclampsia. Who all develop preeclampsia? Just think about it. 4 points, guys. Come on. You write them once, you remember them for life. Okay, not for life, but till the exams you can remember. And I want you to remember because that's how it's going to be. Okay, if you don't think I'm going to sit and spoon feed you. I am going to do that anyways. But I need you also to, see, this is going to be finally helpful to you if you rattle your brains. Finally, that's going to help you. If you just listen and read to me, you will forget like this. Okay, I'm waiting, guys. Try, all of you in the class, try. So I think people are still thinking that it's my class is at 9. So many of them are not there. Unfortunately, I also forgot messaging my students, which I usually do before the class. Okay. Okay. How many of you remember that I gave you a table in which there were these high risk factors and moderate risk factors for the starting of aspirin? You don't remember. So there is a table that I shared with you. There's a table that I shared with you which had high risk factors and moderate risk factors. And these risk factors were telling us one of the high risk factors is sufficient to start aspirin in pregnancy. Because why do we start aspirin? Is one of the aspirin is a prophylactic measure so the patient does not develop hypertension in this pregnancy, correct? So what happens is that when we were there are certain risk factors which only by itself the risk factors are sufficient to tell us that this patient will develop preeclampsia. You better start her on aspirin. And the same risk factors will come here as well. So primary gravida is okay. Previous kidney disease is fine. Previous history of preeclampsia and previous pregnancy. Previous a patient with chronic hypertension. These are all high risk candidates to develop preeclampsia. And what have my students written? Yes, obesity. Obesity above BMI 35. Age more than 40. These are moderate risk factors. The high risk factors are the ones patient having SLE. Okay, patient having previous history of chronic kidney disease, previous history of preeclampsia, chronic hypertension, a patient with chronic hypertension. All these are risk factors. Okay, all of you have written very well. Great. Gestosis score is one of the scorings in which we can extremes of HC and multiple pregnancies. Correct. So these are the reasons. These are few of the important risk factors for the development of preeclampsia. This is a very, very, what do I say, stupid question to ask, because it's just enumerating four, what do I say, causes. What are we going to write down in this? Just a word or two, and they're giving 4 marks to such a small question. Okay.